Hey everybody, this is going to still be the part 1 of chapter 10, but video 2. We left off with getting into the electrical conductivity of the heart, and we want to review some of the basics of EKGs before we jump into dysrhythmias. The book kind of ties together the EKG and the dysrhythmia portion together, and then we move into like ischemic heart disease and those things. So let's jump over to our osmosis videos. This is the electrical conduction in the heart video.
So, electrical conduction in the heart refers to the electrical signals that go from cell to cell in the heart. This happens in the form of action potentials, which get sent out by the pacemaker cells in the heart. The pacemaker cells, also called conducting cells, are a relatively tiny group, only about 1% of the heart cells, but they're a pretty influential minority. Their special ability is that they're autorhythmic, which means that they're able to continually generate new action potentials that go out to the rest of the heart, which are the other 99%. This is different from how it works in skeletal muscle cells, which get their action potential signals directly from neurons. The cells that receive the cardiac action potential from the pacemaker cells are called myocytes, and they make up the myocardium, which is the muscular middle layer of the heart. Myocytes are also called contractile cells, because they contract and that's how the heart pumps blood. Action potentials are initiated by depolarization, which is the opposite of polarization. In this case, polarization is when there are more positive ions outside the cell than inside. This difference in charge is called the membrane potential, and is negative since there are more positive ions outside the cell. So depolarization is when the membrane potential gets smaller, making a cell slightly more positive than it would normally be. Imagine a negative, gloomy cell experiencing a brief moment of joy. If one cell after another depolarizes, then there's a depolarization wave, which is just like a crowd of people doing the wave at a football stadium. So there are a group of pacemaker cells in the sinoatrial node, or SA node, which is a small sinus or cavity tucked up into the right atrium. During each heartbeat, one pacemaker cell out of the group will automatically depolarize first. In fact, each heartbeat might be led by a different cell in the group, but eventually at least one of them will fire because they're all autorhythmic, meaning that every pacemaker cell has the ability to self-generate a new action potential, given enough time. So as a group, the pacemaker cells of the SA node act like a drill sergeant that gives orders to the rest of the heart. They decide when the heart contracts and when it relaxes, so they set the heart rate. The depolarization wave that comes out of the SA node moves really fast through the pacemaker cells throughout the heart, and moves more slowly through the atrial and ventricular myocytes. Some pacemakers lie along atrial internodal tracts, also called Bachmann's bundle, which connects the SA node to spots in the right and left atria, so that the depolarization wave can quickly reach atrial myocytes in both atria. When the atrial myocytes get depolarized, they contract, which pushes blood from the atria into the ventricles. While this is happening, the depolarization wave also travels from the SA node through the pacemaker cells to the atrioventricular or AV node. Conduction velocity slows way down at the AV node, and this happens for two reasons. First, the AV nodal cells have very small diameters, which increases resistance to electrical flow. And second, the AV nodal cells use the relatively slower opening calcium ion channels rather than the faster opening sodium ion channels. The AV node is the only point where an electrical signal can go from the atria to the ventricles. And since the depolarization wave causes muscle contraction, this slight conduction delay is crucial in allowing the ventricles to have plenty of time to fill with blood before they contract. So let's say that for some reason the conduction through the AV node is sped up. Well, in that situation, there's less time for ventricular filling, and so there'd be a decrease in stroke volume and cardiac output. From the AV node, the depolarization wave travels through the conducting system of the ventricles. First, it goes to the bundle of His, and then into the left and right bundle branches and into the Purkinje fibers. The Purkinje fibers are the final bit of conductive tissue that spread the depolarization wave to the rest of the heart. The His-Purkinje system conducts the depolarization wave really fast, and this is important because it makes the heart contract in a coordinated way. If the timing was slightly off and the ventricles didn't contract all at once, blood would sort of slosh back and forth, rather than getting forcibly pushed out to the lungs and body. One really cool thing about the heart is that if the pacemaker cells in the SA node fail to fire, there's not only a plan B, but a plan C and plan D as well. Pacemaker cells in the SA node have short action potentials and short refractory periods, so right after depolarizing, they want to depolarize again. That's called the firing rate, and at rest, the SA node has a firing rate of 60 to 100 depolarizations per minute. It turns out, though, that there are pacemaker cells in other parts of the atria that have a slightly slower firing rate of 60 to 80 depolarizations per minute. There are also pacemaker cells in the AV junction that have a firing rate of 40 to 60 depolarizations per minute. And pacemaker cells in the ventricles, specifically in the bundle of His and Purkinje fibers, that have a firing rate of 20 to 40 depolarizations per minute. So if the SA node fires on time, then it resets all of the other pacemaker cells, and that's why it sets the pace. If the SA node doesn't fire, then atrial pacemaker cells finally get a chance to start firing, and they get to set the pace, resetting the pacemaker cells in the AV junction and ventricle. If the atrial pacemaker cells fail, the AV junctional pacemaker cells take over. And finally, if all the other pacemaker cells fail, then the ventricular pacemaker cells start pacing the heart. Once any of these groups of latent pacemaker cells steps up, it's called an ectopic pacemaker, or ectopic focus, meaning that the pace is being set from a place other than the usual spot, which is the SA node. Alright, as a quick recap, pacemaker cells in the SA node send a depolarization wave through the atria so they can contract together, as well as to the AV node where there's typically a delay so that the ventricles can fill with blood. From there, the depolarization wave races down the bundle of His and Purkinje fibers and spreads out through both ventricles, which allows them to contract together. If the SA node fails, other pacemaker cells in the atria, AV junction, and ventricles are ready to step in to take over.
So I'm going to keep in pace with the book and with the idea of how they do it throughout the chapters. So next, the book goes into this brief introduction on looking at the cardiac cycle and the EKG. So I'm going to kind of jump in here, and we are going to create our own edition of the EKG and tying in osmosis at this point, and then we'll be able to jump back into the book and cover their arrhythmias. So we are adding quite a bit of content from osmosis that's not covered in the book, but is incredibly important for us to know. So we are going to jump in here and kind of create our own, if you will, section on EKG. So I'm going to jump over to osmosis. So what we're going to do is make up our own little version then of EKG training based on the osmosis videos. I'm going to walk through the videos with you, and we're going to tie in some of the content from the book. Remember, anything in this is testable, and so we will certainly want to make sure you're listening and following along. So we're going to start with ECG basics.
An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down into the left and right ventricles. To understand the basics, let's start with an example of how we can look at the heart with only one pair of electrodes, a positive one and a negative one. Remember that at rest, cells are negatively charged relative to the slightly positive outside environment, and when they depolarize, the cells become positively charged, leaving a slightly negative charge in the outside environment. So let's say that when this set of cells is at rest, they're red, and then they turn green as the wave of depolarization moves through them. Now, if we freeze this wave of depolarization as it's moving through the cells, half of the cells are positive or depolarized, and half are negative or resting. And so there's a difference of charge across this set of cells. You can think of the charge difference as being a dipole, because there are two electric poles. And we can draw this dipole out as an arrow or vector pointing towards the positive charge. And remember, the electrodes detect charge on the outside of the cell. So this points toward where the positive charge is outside the cell. Now, if there's a dipole vector pointing toward the positive electrode, then the ECG tracing shows it as a positive deflection. The bigger the dipole, the bigger the deflection. If we unpause this, then everything becomes depolarized. And since there's no difference in charge now, there's no dipole, and so there's no deflection. Moments later, a wave of repolarization goes through. Pausing halfway through again, now the vector dipole goes in the opposite direction and faces the negative electrode, which means there'll be a negative deflection on the ECG tracing. Again, the bigger the dipole, the bigger the negative deflection. Now, even though it'd be nice if the depolarization wave lined up perfectly with the electrodes, usually that's not the case. So what we end up looking at is a vector component that's parallel to the electrode. For example, let's say the depolarization happened this way, at an angle. Then we'd break the vector into two parts, one going parallel with the electrodes and one going perpendicular. The one we care about is the one that's going toward the positive electrode, which causes the deflection. Though since this arrow is shorter, it's going to cause a slightly smaller deflection than previously. In other words, the size of the deflection on the ECG tracing always corresponds to the magnitude or size of the dipole in the direction of the electrode. The perpendicular component isn't pointing at the electrode, so it doesn't cause any deflection. In fact, if there's a depolarization wave that goes straight up, which is perpendicular to the positive and negative electrodes, then there'd be no deflection at all. In a standard ECG, there are 10 electrodes. 4 limb electrodes, one on the left arm, left leg, and right leg, and 6 precordial electrodes, V1 through V6, that wrap around the chest. And the right leg electrode is usually used as a neutral lead. Now, the heart's a 3-dimensional organ, right? So V1 through V6 line up in the transverse or horizontal plane of the heart, and each electrode is set up to detect any wave of positive charge coming toward them, which based on what we know already means that they're positive. These are collectively called the chest leads. Meanwhile, in the coronal plane, the non-neutral leads are called augmented vector right, or AVR, on the right arm, and augmented vector left, or AVL, on the left arm, both of which are represented as vectors that are 30 degrees up from the horizontal line. Finally, there's the augmented vector foot, or AVF, on the left foot, which anatomically isn't straight down, but it's close enough that it ends up representing the vector facing straight down on the diagram. Just like the precordial electrodes, AVR, AVL, and AVF each detect any positive deflection coming toward them. Now, in addition to these 3 limb leads, there are also bipolar limb leads called lead 1, 2, and 3, which are recorded using 2 electrodes instead of just 1. Lead 1 uses the right arm as the negative pole and the left arm as the positive pole, forming a vector that goes to the right. Lead 2 uses the right arm as the negative pole and the left leg as the positive pole, forming a vector that goes to the plus 60 degree mark. And lead 3 uses the left arm as the negative pole and the left leg as the positive pole, forming a vector that goes to the plus 120 degree mark. So in total, you've got 6 leads from the limb leads and 6 from the chest leads, leading to a grand total of 12, which gives you your 12-lead ECG. Now, the point of having all these leads is to get different views of the heart, making it easier to see exactly how that wave of depolarization moves through the heart. As an example, consider how the 6 chest leads, V1 through V6, register the depolarization waveform called the QRS complex. The exact same depolarization wave might appear mostly negative in V1 and V2. It might be isoelectric in V3, and mostly positive in V4, V5, and V6, all because of the exact direction and magnitude of the vectors at different points in time. Similarly, each of the limb leads produces its own viewpoint of the depolarization wave as well. Now, all the limb leads and chest leads can be grouped based on the regions of the heart that they're nearest. Problems in specific leads or groups of leads suggest that there might be a specific region of the heart that might be affected by a disease. Leads 2, 3, and AVF are inferior leads because they're near the inferior wall of the heart, which receives blood from the right coronary artery. Leads 1 and AVL, along with 2 of the chest leads, V5 and V6, are all considered lateral leads because they're near the lateral wall of the heart, which receives blood from the left circumflex artery. Finally, V1 and V2 are considered septal leads because they're nearest to the interventricular septum, and V3 and V4 are anterior leads because they're nearest the anterior wall of the heart. Both of the septal and anterior regions are served by the left anterior descending artery. Alright, as a quick recap. In a standard ECG, there are 10 electrodes, 4 limb electrodes and 6 precordial electrodes that wrap around the chest. These electrodes are used to make 12 leads, each of which illustrates the movement of positive charge on the outside of heart cells. The ECG tracing shows a depolarization wave moving towards an electrode as a positive deflection, and one moving away as a negative deflection, each of which is proportional to the size of the dipole. The point of being able to get different views of the heart is that it makes it easier to see how the wave of depolarization moves, which provides valuable information about the heart's structure and function. Thanks for watching this video on the basics of ECG. But actually, this is only episode 1 of an 8-part series on ECG. To get access to those 7 additional videos, head over to osmosis.org, create an account, and start your free trial. In addition to extra videos, you can also find tons of other awesome
That was the ECG basics. They do have this 8-part series that are on here that we're going to kind of work our way through some of those. So we're going to talk next about rate and rhythm. I'm going to do this one at a little faster voice over. These are all going to be on your list of playlists, so you can watch again at your leisure at a slower speed if you'd like.
An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down into the left and right ventricles. To read an ECG, there are a few key elements to keep in mind. One of them includes figuring out the rate and the rhythm. Now, there are a couple ways of figuring out the heart rate on an ECG. The first one is called the box method because you count the number of boxes between heartbeats. Each small box represents 0.04 seconds, and each big box is 5 small boxes. So each big box is 0.2 seconds. So to calculate the heart rate, you can count the number of small boxes between R waves, since R waves are tall and pointy and easy to see on lead 2 of an ECG strip. You can find an R wave that has a peak that falls at the beginning of a box, and then count up how many boxes until the same point on the next R wave. So let's say that there are 4 big boxes and 1.5 small boxes between 2 R waves. Since you have 4 big boxes, that means 4 times 5 small boxes, plus that extra 1.5 small box, totals to 21.5 small boxes. And that means that there are 0.04 seconds times 21.5, or 0.86 seconds between heartbeats. So the units here are seconds per heartbeat. Now, to get something a little more meaningful, we can take the inverse of that, which is 1 over 0.86 beats per second, or 1.16 beats per second. Now, since there are 60 seconds in a minute, we can multiply this by 60 and end up with 70 beats per minute, which is the heart rate. Now, if the distance between 2 R waves is exactly 1 box, then the heart rate would be 300 beats per minute, which is really fast. If R waves are 2 big boxes apart, or 0.4 seconds, then the heart rate is 150 beats per minute. 3 big boxes apart is 100 beats per minute, 4 big boxes is 75 beats per minute, 5 big boxes is 60 beats per minute, and finally 6 big boxes apart is 50 beats per minute. Remembering these numbers makes it easier to make a rough estimate of the rate. For example, if there are between 3 and 4 big boxes between R waves, then we know that the heart rate must be between 75 and 100 beats per minute. Another method to figure out the heart rate is to count the number of beats in 10 seconds, which is the standard length of time in the rhythm strip portion of a 12-lead ECG. So in this case, we can count 15. Since this is a 10-second interval, all you have to do is multiply this by 6 to get the heart rate, which would be 90 beats per minute. The reason this little trick works is because you have 15 beats per 10 seconds. And again, to convert to per minute, you multiply by 60 seconds in a minute. Looking at this, we see that 60 divided by 10 equals 6 per minute. So 6 times 15 is 90 beats per minute. If the heart rate is too fast or too slow, it could be because something other than the SA node is pacing the heart. For example, there could be atrial flutter, which is when an ectopic focus in the atria, like an irritated atrial cell, starts to spontaneously fire between 250 and 350 depolarizations per minute, with only 1 out of every few atrial depolarizations passing through to the ventricles. To calculate the atrial rate, you can use the same methods as before, except you look at P waves instead of R waves. If one P wave starts on a heavy line, and the next P wave starts in the next heavy line, or 0.2 seconds later, then again you've got 1 beat for every 0.2 seconds. And multiplying by 60 seconds in a minute, you get 300 beats per minute. You could also remember that nifty trick where 1 big box is equal to 300 beats per minute. Another situation is atrial fibrillation, which is when there are multiple ectopic foci in the atria that start firing all at once. The atrial rate here can increase to 350 to 450 beats per minute. In this situation, only the occasional firing of an ectopic focus that happens to be near the AV node is able to make it through and down to the ventricles. The ectopic foci fire too quickly for the atria to be fully depolarized by any one of them. So with atrial fibrillation, there aren't any P waves on an ECG, but rather small waves that reflect waves of atrial depolarization that couldn't make it through the AV node. Of note, the 350 to 450 beats per minute reflects all the times the atrial foci fire in a minute, and not the rate of the ventricular depolarization. So with atrial fibrillation, the ventricular rate is much lower than the atrial rate, but still over 120 beats per minute, and highly irregular, meaning that the distance between the QRS complexes is not equal. Normally on an ECG, one waveform with its P wave, QRS complex, and T wave looks just like the next one, almost like they were just copied and pasted one right after another. And that's how a regular rhythm looks. An irregular rhythm, on the other hand, is when there's any change in the timing of the QRS complexes. To help identify ECG abnormalities, you can look to see if every part of the waveform looks exactly the same, which would include the P wave, the QRS complex, and the T wave. If not, it could mean that there's an ectopic beat, meaning that it might have originated from an abnormal spot in the atria or ventricles. For example, this first P wave is deflected upwards, and the second is deflected downwards, which would indicate that it's an ectopic beat. Alternatively, an odd-looking waveform might have originated from the normal spot, which is the SA node, but then gotten thrown off course, which is what happens when there's a block someplace. In this example, there's a bundle branch block, which is where the signal can't go down one or both of the bundle branches, and this usually results in these wide QRS complexes. Next, you could check for changes in the sequence of the waves, most often involving the two depolarization waves, the P wave and the QRS complex. You can look to make sure that there's a P wave before every QRS complex, as well as a QRS complex after every P wave. For example, if there's a premature ventricular contraction like this, then there might be a QRS complex without a preceding P wave. On the flip side, if there's a third-degree AV block, the atria and ventricles have completely separate electrical activity, kind of like two people dancing to different songs at the same time. So in this case, there can be P waves that are not followed by QRS complexes, and the ventricular rate is usually low, around 40 beats per minute. Also, don't forget the most common irregular rhythm, which is atrial fibrillation, in which case there are no P waves, and irregular QRS complexes. Alright, as a quick recap, one quick way to estimate the heart rate on an ECG is to remember that one big box is 300 beats per minute, two big boxes is 150 beats per minute, three big boxes is 100 beats per minute, four big boxes is 75 beats per minute, five big boxes is 60 beats per minute, and six big boxes is 50 beats per minute. To help identify an irregular rhythm, you can look at the waveforms and see if there's any variation in the timing of the QRS complexes.
Then we are going to go into, so we're going to jump into the PVC. And I'm going to play this at a faster rate for us here, so it's a lot faster than the 12 minutes. I want you guys to listen to this and not be too worried about taking a ton of notes. I just want you to hear this material and understand what a PVC is, so you have a good grasp on that when you're on practice.
The heart has two lower chambers, called the ventricles, so a premature ventricular contraction is when the ventricles contract earlier than normal in the cardiac cycle. This happens because an abnormal contraction signal, called a depolarization, originates from somewhere in the ventricles, rather than coming from the pacemaker cells. So if we simplify this heart a little bit, normally the sinoatrial or SA node sends an electrical signal that propagates out through the walls of the heart and contracts both upper chambers. Then that signal moves to the atrioventricular or AV node, where the signal is delayed for a split second. And then it goes down into the ventricles or lower chambers, where it moves down the bundle of His into the left and right bundle branches, and into each ventricle's Purkinje fibers, causing them to contract as well. So in a healthy heart, the upper chambers contract first, then shortly after the lower chambers contract. On an electrocardiogram or ECG, which measures the electrical activity of the heart via electrodes that are placed on the skin, the atrial depolarization, and therefore its contraction, is seen as a P wave. The ventricular contraction is seen as a QRS complex, and the ventricular repolarization, and therefore its relaxation, is seen as a T wave. This empty space here is called the PR segment, and it corresponds to the pause in the AV node. And this one is called the ST segment, and it corresponds to the interval between ventricular depolarization and repolarization. And this one's called a TP segment, which represents the heart's quiet time when the cells are finished repolarizing and are ready for another signal. Now, if we just look at the QRS complex, which normally lasts less than 100 milliseconds or 2.5 little boxes, it's usually made up of 3 smaller waves, also called deflections. If the first wave after the P wave is downwards or negative, it's called a Q wave, which you can remember by the letter Q having a downward tail. If the next deflection is upward or positive, then it's called an R wave. If, though, the first wave after the P wave is upwards instead, or positive, you basically skip the Q and just call it an R wave. Finally, any downward deflection after the R wave is called the S wave. Now, the interesting thing is that in addition to the pacemaker cells in the SA node, cells in the AV node, the bundle of His, and the Purkinje fibers all have the ability to generate an electrical potential. Those last three are called latent pacemakers, and they have slower depolarization rates, which is the rate at which they fire off electrical signals, and they get slower as you move further down. Let's use this bar to visualize the SA node's depolarization rate, which is the fastest, and then each one below is slightly slower. Notice that each time the SA node fires, it resets all the slower ones, and this is exactly how it works. If, for example, the SA node stopped altogether, then the AV node would take over at its slightly slower pace. Now though, let's say you have a ventricular ectopic focus somewhere in the ventricles, which is a cell or area of tissue that sends off an early depolarization wave, before even the SA node gets to fire. This is what leads to a premature ventricular contraction, or PVC. One cause of a latent pacemaker cell or a cardiac muscle cell depolarizing early is it gets enhanced automaticity, which might result from irritating stressors like electrolyte imbalances, drugs like cocaine or methamphetamines, ischemic damage like a heart attack, or anything that increases sympathetic activity, like anxiety. Ectopic beats can also have triggered activity, which is where cells depolarize early. The exact mechanism here, though, is unclear, but it might be due to an ion channel dysfunction that leads to an unexpected change in the membrane potential during or right after repolarization. When a cell depolarization happens during ventricular repolarization, it's called an early after depolarization, and if it happens after repolarization is finished, it's called a delayed after depolarization. A final type of ventricular ectopic focus is a reentrant loop, where a depolarization wave encounters tissue that doesn't depolarize, which could be something like scar tissue after a heart attack. And as a result, the wave starts going around and around that tissue, forming what's called a reentrant loop. A reentrant loop basically starts sending out depolarization waves to the rest of the heart tissue each time the wave goes around. If the ectopic focus originates in the right ventricle, the wave will depolarize the right ventricle first and then the left ventricle, and this produces a QRS complex that looks like a left bundle branch block. If the ectopic focus originates in the left ventricle, the wave will depolarize the left ventricle first and then the right ventricle, which produces a QRS complex that looks like a right bundle branch block. Now, lead V1 on an ECG measures a depolarization wave that moves toward the right ventricle. So when an ectopic focus originates in the left ventricle and moves toward the right ventricle, the V1 lead shows a large positive complex, with a dominating R wave. When an ectopic focus originates in the right ventricle and then moves toward the left ventricle, the V1 lead shows a large negative complex, with a dominating S wave. Regardless of the originating ventricle, a premature ventricular contraction often has an abnormal T wave, since the timing and direction of repolarization will be abnormal as well. Alright, so let's say that the heart's cruising along at about 60 beats per minute, which means that there's 1 second between P waves and QRS complexes. All of a sudden, an ectopic focus in the ventricles fires off, which contracts the ventricles, and that wave of depolarization tries to travel up to the atrium. But since this happened so close to the previous depolarization, the atrium's still in its refractory period, so the wave gets stopped at the AV node. A split second later, the ventricle enters its refractory period. Since the sinus node's going at 1 beat per second, and it's out of refractory, it fires off a signal, and the atria contracts and you get another P wave, which is right on schedule. But this time the opposite thing happens, and the ventricle's in refractory, so it doesn't contract. Now both relax and come out of refractory, and exactly 1 second later the sinus node sends another signal and the atrium contracts as it should, and then everything carries on as per usual. This situation is called a compensatory pause, which is defined as having a normal sinus complex landing exactly 2 times the normal sinus interval, which was 1 second, so 1 times 2 equals 2 seconds. What ends up happening here is there's this big long pause between ventricular contractions, which is greater than the sinus interval. Longer time between contractions means more ventricular filling, which means the heart contracts with greater strength, which can be felt as a palpitation. Alright, now let's run a slightly different scenario, one where the PVC comes a little bit later, after the atrium comes out of refractory. In this case, the wave of depolarization makes it into the atrium and depolarizes the atrium, including the sinus node. So essentially, the sinus node resets about 4.4 boxes from the last, or 0.88 seconds. In this case, after being depolarized, the sinus node waits its 1 second, and then sends another signal, and again we carry on as normal. This time we call this a non-compensatory pause, because the sinus complex lands less than 2 times the normal sinus interval. And this is how you can tell if the PVC depolarized the atrium or not. A ventricular ectopic focus can fire at different points in the cardiac cycle, which we can look at using the ECG. First off, it might happen during a P wave, which can get completely lost in the QRS complex, but can sometimes be seen if you search for it. Next, the ectopic beat could happen during the PR segment, and because the ectopic depolarization happens relatively slowly, oftentimes it'll combine with a normal depolarization wave coming down the ventricular conduction system, resulting in a ventricular fusion beat. These can appear lots of different ways, depending on where the 2 depolarization waves meet each other. Early after depolarizations might start during the ST segment, or even during the T wave, which is called R on T phenomenon. This used to be considered an ominous sign of an impending dangerous arrhythmia, but recent studies show that this might be a bit more unclear than once thought. Sometimes premature ventricular contractions can keep happening, rather than be isolated events. For example, ventricular bigeminy is when a premature ventricular contraction consistently comes after each normal cardiac cycle. Ventricular trigeminy, on the other hand, is when one consistently comes after every 2 normal cardiac cycles. Also, you might have multiple ectopic foci firing off PVCs, which end up producing different appearing QRS complexes on a single rhythm strip. Now, most people with premature ventricular contractions don't notice them, but if they keep happening, they can cause lightheadedness because of less blood getting delivered to the brain. In rare situations, an ectopic focus can trigger ventricular tachycardia, or even ventricular fibrillation, which are both serious arrhythmias where the ventricles beat too quickly to fill up with an adequate amount of blood. The diagnosis of a premature ventricular contraction is based on an ECG, but sometimes a Holter monitor, which is like a continuous ECG monitor used over a few days, is needed to capture the event. Typically, premature ventricular contractions don't need treatment, and if there's an obvious cause like a medication or a use of a substance, then stopping that typically resolves the issue. If the premature ventricular contractions keep happening or cause palpitations, they can be treated with beta blockers or calcium channel blockers, both of which prevent the heart from beating too strongly. If an ectopic focus is triggering ventricular arrhythmias, radiofrequency ablation can be done, which is where radiofrequency waves are used to destroy the tissue that's causing the ectopic heartbeat. Alright, as a quick recap, premature ventricular contractions are abnormal heartbeats that originate in the ventricles, and show up as tall and wide QRS complexes on an ECG. They can be caused by abnormal automaticity, re-entry, or a triggered after depolarization. They're usually asymptomatic, but when they're a sign of an underlying disorder, treatment including a radiofrequency ablation might be necessary.
So now, following kind of into the book, when they start talking about some of the dysrhythmias, one of the ones they go into is Brugada syndrome. I would say that Brugada syndrome is one of the things that tends to creep up in terms of board examinations, a very typical certification board question.
Brugada syndrome is named after 2 Spanish brothers, Pedro and Joseph Brugada, who recognized a specific pattern of ventricular fibrillation on the electrocardiogram, or ECG, of previously healthy individuals who had a sudden death. They identified this as Brugada syndrome, and found that some cases could be traced back to a specific genetic cause. Many individuals with Brugada syndrome don't have an identifiable genetic cause, but in some individuals there is one. The most well-known cause is a mutation in the gene SCN5A. The SCN5A mutation is inherited in an autosomal dominant pattern, meaning a single mutation is enough to cause the disease. The gene codes for sodium ion channels in the cell membranes of cardiac muscle cells, and a faulty sodium ion channel affects the heart cell's ability to conduct an action potential. So the mutation results in some regions of the heart having abnormal repolarization. In some cases, the heart might have a normal rhythm, but then develop a Brugada syndrome rhythm in the presence of certain medications, like sodium channel blockers. On an electrocardiogram, Brugada syndrome typically has ST elevations, which are often a sign of ventricular strain, as well as right bundle branch block, which indicates that the ventricles aren't depolarizing normally. As a result, these regions become susceptible to a re-entrant loop, which is when depolarization signals start going around and around in a loop, causing a ventricular tachycardia and sometimes ventricular fibrillation. Ventricular fibrillation, sometimes called VFib, means that the heart's muscle fibers start quivering because they're not contracting at the same time. Normally, an electrical signal spreads fast enough so that all of the muscle fibers in the ventricles contract almost at the same time, which essentially looks like a single coordinated contraction. If they don't all contract at the same time, not much gets accomplished. It's kind of like a rowboat. It works best when everyone rows at the same time, right? Well, with VFib, all of the rowers stop rowing together and just row whenever they want, and the rowboat just moves in circles and eventually sinks. Just like the rowboat, if the heart's not squeezing anymore and it's just squirming around like a bag of worms, which is actually used to describe what it looks like, then you can probably guess that this situation is extremely dangerous, since your body, and especially your brain, isn't getting fresh oxygen, meaning ventricular fibrillation can lead to death within minutes of onset, and this is called sudden cardiac death. Individuals with Brugada syndrome are usually healthy and then die suddenly. In some cases, individuals survive their first episode of an arrhythmia, which might cause palpitations, shortness of breath, and fatigue, and then they're diagnosed. Other times, family members of somebody that dies get diagnosed with a genetic test. Individuals with Brugada syndrome can have a cardiac defibrillator implanted, so that it can take over in case they develop a ventricular fibrillation. Alright, as a quick recap, Brugada syndrome is usually identified based on an ECG tracing and is a cause of sudden cardiac death. Some cases have been linked to a gene mutation in SCN5A, which encodes a sodium channel found on cardiac muscle cells. Ultimately, Brugada syndrome can lead to ventricular fibrillation, which is when the ventricles contract in an uncoordinated way, and in some cases a defibrillator is implanted to prevent sudden cardiac death.
The PQR.
QT syndrome and torsades.
On a normal ECG, you've got the P, Q, R, S, and T waves. The QT interval spans from the start of the Q to the end of the T wave. Long QT syndrome, or LQTS, is when somebody's QT interval is longer than normal, which should typically be less than half of a cardiac cycle. In fact, for a heart rate of 60 beats per minute, the QT interval is generally considered to be abnormally long when it's greater than 440 milliseconds in males or 460 milliseconds in females. If you measured someone's QT interval at a different rate though, say 90 beats per minute, and it was 400 milliseconds, you can't really use that to compare to these values at 60 beats per minute, since the QT interval changes depending on the rate. As rate increases, the QT interval decreases. So what we have to do is find the corrected QT interval, or QTC, at the different rates so that you can compare it to the QT interval at 60 beats per minute. Even though there are a couple formulas you can use, the Bazette formula is probably the simplest, where the corrected QT interval equals the QT interval in milliseconds divided by the square root of the R to R interval in seconds divided by 1 second. As a bit of a side note, usually this formula is expressed without the divide by 1 second bit. But the astute observer will notice that the units won't work out if you do that. Interestingly, the original formula did include dividing by 1 second to get the units to work out. But for some reason in a paper way back when, that step wasn't included, and basically the version without the 1 second, the sort of unit incorrect version, has been used ever since. Anyways, let's do a quick example of a male with a 400 millisecond QT interval at a rate of 90 beats per minute. Comparing to the values at 60 beats per minute, 400 milliseconds wouldn't be considered a long QT, right? If we use our handy formula though, we'll plug in 400 for QT and 90 beats per minute, or 0.66 seconds per beat. So we have a QT of 400 milliseconds divided by the square root of 0.66 seconds over 1 second, which is 400 milliseconds divided by 0.81, which is unitless. And we get a corrected QT interval of 493 milliseconds, which is greater than 440 milliseconds. So actually, a 400 millisecond QT interval at 90 beats per minute is considered long. Alright, so the QT interval is a little long. What's wrong with that? Well, the QRS complex corresponds to the ventricles depolarizing and contracting. After they depolarize, they have to repolarize, and that's captured by the T wave. When someone has a long QT interval, it means that they have an abnormally long repolarization of some of their heart cells, but not all of their heart cells, which is an important point to remember. Specifically, some of the heart cells are taking longer than normal to repolarize compared to their neighboring heart cells. Having some cells with an abnormally prolonged repolarization phase is thought to be caused by abnormalities in the movement of ions through ion channels, which is responsible for both depolarization and repolarization. And each time it depolarizes and repolarizes, it's called a cardiac action potential, where ions flow in and out of the cell. And this happens in 4 phases, which we can plot on a graph of membrane potential over time. During phase 2, potassium channels open and let potassium flow out, which tends to want to make the membrane potential more negative. But L-type calcium channels open and let calcium flow into the cell, which tends to want to make the cell more positive, and therefore it maintains the plateau phase. During phase 3, the potassium channels stay open, but now the L-type calcium channels close, which lets the cell repolarize. So it's thought that dysfunction in the L-type calcium channels is one mechanism that can lead to a long repolarization phase. Specifically, they might let in more calcium during phase 2, making the membrane potential more positive and causing an early after depolarization, or an EAD. Other mechanisms involve sodium and potassium ion channels, which can also malfunction and cause EADs as well. If the EAD is large enough, it might propagate out and depolarize the ventricles, causing a premature ventricular contraction, or a PVC. In other words, an unexpected ventricular contraction. If at this point some neighboring cells are ready for another depolarization, and some cells aren't, then that wave of depolarization will propagate through the ready cells, but get blocked by the not ready cells. Then at some point when those not ready cells come around, the wave of depolarization can double back, potentially creating a re-entrant circuit, which leads to re-entrant tachycardia, which are super fast heart rates that can happen because the signals might propagate around in a circular way, over and over and over again. This becomes a special type of ventricular tachycardia, or VT, which is associated with long QT syndrome, called torsade de point, which means the twisting of points, because the QRS complexes seem to twist around the isoelectric line. And since the QRSs are different in shape, this is more specifically a type of polymorphic VT. Rates for torsade range between 150 and 250 beats per minute, the upper end of which is really fast, right? So although these episodes can revert to a normal rhythm spontaneously, they can also be really serious, and people with torsade can feel palpitations, dizziness, and syncope, or fainting. And it can even potentially lead to sudden cardiac death. Alright, so with long QT syndrome and torsade, the cause of these abnormal ion channels is often congenital, meaning it's present at birth and caused by some genetic abnormality. There are at least 10 specific gene mutations that are known to be linked with long QT syndrome, which are referred to as, for example, LQT1, LQT2, and so on, all of which have some effect on one or more ion channels. Aside from congenital causes, though, sometimes the QT interval can be prolonged by certain medications, which affect ion channels. For example, Class 1A antiarrhythmic drugs block sodium and potassium channels, while Class 3 block potassium channels. And these effects can lead to QT prolongation and an increased risk of torsade de point in some patients. Drug-induced LQTS usually returns back to normal on stopping the causative medication. However, once torsade de point develops, immediate treatment is required to prevent sudden cardiac death. The treatment of choice is magnesium sulfate, which acts by suppressing the EAD. Alternatively, electrical pacing or medications that increase the heart rate might be given to decrease the QT interval. Alright, as a quick recap. Long QT syndrome, or LQTS, is when the QT interval in an ECG is more than half of a cardiac cycle, or greater than 440 milliseconds for males, or 460 milliseconds for females, with a heart rate of 60 beats per minute. It's caused by abnormally long repolarization of some of the heart cells, due to congenitally abnormal sodium, potassium, or L-type calcium channels, or medications like Class 1A and Class 3 antiarrhythmics. LQTS gives rise to a re-entrant circuit, which can result in a type of polymorphic ventricular tachycardia, called torsade de points, which is treated with magnesium sulfate or electrical pacing.
Then we are going to review quickly Brugada syndrome, which is one of the ones that they talked about in the book as a specific kind of pathophysiology related to an arrhythmia. Brugada syndrome, like I said, is something that I do think we see on board questions quite a bit, which is why I wanted to make sure that you guys had it included as a highlighted topic for us. Okay, the really big thing is the two things you want to remember is that it's the SCN5A autosomal dominant mutation, and then that the clue is what you see in your EKG with varying forms of ST elevation in leads V1 through V6. The issue is that it can be chronic or intermittent, and so it's not something that you want to miss. Because if you were in an ER, urgent care hospital, whatever, and someone came in and you missed a Brugada and then they went on and died, that would be a bad thing, right? Most people that end up with a Brugada will end up with a implanted ICD to prevent sudden cardiac death. Then the book goes into a little bit of the long QT syndrome. Again, it's another inherited disease, or could be acquired. EKG has a prolonged QT duration, and this is a bad thing because it enhances the excitability or delaying repolarization of the non-pacemaker action potentials. Many subtypes will have varying degrees of vulnerability to sudden cardiac death. The thing you should associate with long QT syndrome also is that it can precipitate torsades de pointes, which obviously is a form of sudden cardiac death. If you have a history of long QT syndrome, you certainly are not going to be able to take certain medications. You also would want to make sure that serum potassium and magnesium levels are not allowed to get too askew in someone with long QT syndrome because that would put them at risk as well for torsades de pointes. You don't need to get too caught up in this part here. I don't want you to spend a whole lot of time trying to read through and memorize or anything, but you could go to your text if needed to talk about these. So then next into your book, they start talking about some of the different atrial fib, atrial flutters, and some of the AV reentrant. A couple of highlights that the book goes through to make sure we understand general mechanisms of arrhythmias. They want us to make sure we understand that you can have a spontaneous impulse generated from a source outside of your SA or AV node, and that is considered ectopy. We all have ectopy. It can be normal, but it's the frequency of it, or if it reduces your cardiac output, that can be a problem. The AV node and the other subsidiary pacemakers have diastolic depolarization, and they can function as their own pacemaker. The AV node or subsidiary pacemakers are usually suppressed by the SA node because it's faster. We can have the latent pacemakers that will kick in for escape rhythms if the SA node fails. Remember that the non-pacemaker cells can develop pacemaker-type characteristics when depolarized or if under certain conditions like ischemia, hypoxia, or infarction. Ectopic and triggered activity can generate extra beats in addition to the sinus beats. So that's what gives us our PACs or PVCs, etc. This image in your book here is just a nice visual for us to see that the failure of the SA node to generate will shift the pacemaker to a progressively lower part of the conduction system. So the SA node at the top should give us sinus rhythm. If the SA fails, we go to a junctional rhythm, and if the junctional rhythm fails, we go to an idioventricular rhythm. This one reminds us that all of us can have ectopy. The PVCs can also occur sporadically, even in the absence of disease, but we certainly worry about frequent PVCs as a sign of myocardial ischemia or irritability. Also, it could be provoked by hypoxia and ischemia, increased sympathetic tone, or abnormal potassium levels being too high. The general mechanism, part 2 of arrhythmias that they say, is that the AV nodal pacemaker can be vulnerable to aging and will be vulnerable to hypoxia. So if someone is truly hypoxic, they can go into block type rhythms, or we have the AV block, etc. type rhythms. You can get bradycardia because you are going to get often non-conducted beats that could go down through to the ventricles. The focal conduction blocks contribute to these reentrant tachycardias. So the book gives us some images to look at that says that we have the characteristics of our normal sinus rhythm, which we've covered on watching the EKG. Remember, at this point, I really want you guys to make sure that you understand what the reflections on an ECG paper are showing us in terms of where we're at during the conduction of the cardiac cycle. So what does the P wave show us? What does the T wave show us? What does the QRX reflect? To make sure we have a good understanding of those. So this would be a normal sinus rhythm. We have a P before the QRS. The P to P maps out. The QRS's map out. It appears to be regular. Then the book goes into some of our AV blocks here as well. So let's jump over to our osmosis and start talking about some of these blocks.
Each heartbeat starts with the heart's pacemaker cells in the sinoatrial node, or sometimes just the SA node, in the right atrium. The SA node sends an electrical signal that propagates out through the walls of the heart and contracts both upper chambers, then moves through the atrioventricular, or AV node, where the signal stops for a split second and then goes down into the lower chambers, where it moves down the bundle of His, into the left and right bundle branches, and into each ventricle's Purkinje fibers, causing them to contract as well. So, in a healthy heart, the upper chambers contract first, then shortly after the lower chambers contract. On an ECG, the atrial contraction is seen as a P wave, and the ventricular contraction is seen as a QRS complex. The interval from the start of the P wave to the start of the QRS complex is called a PR interval, and is normally between 120 and 200 milliseconds, or 3 to 5 tiny boxes on the graph paper that it's usually printed out on, since each box is 40 milliseconds or 0.04 seconds. Heart block describes a type of arrhythmia, or abnormal rhythm, that happens when an electrical signal gets held up and delayed, or blocked entirely, at some point along the conduction system. These blocks or delays usually happen because of some sort of damage or fibrosis to the electrical conduction system, the pathways that conduct the electrical signal. Lev's disease, or Lenigre-Lev syndrome, is used to describe the large proportion of cases that are idiopathic, and described as progressive cardiac conduction defects, meaning it's not clear exactly what causes it.
Is not something I'm testing you on.
But over time, fibrosis, or scarring, develops in the conduction system which can delay or stop electrical conduction. This is usually a result of the aging process in the heart, and happens most often in the elderly, although some hereditary forms have been identified and can happen in younger people. Another large proportion of cases, though, are a result of ischemic heart disease, when the heart cells don't receive enough oxygen and can die off, as with a heart attack. This again leaves scar tissue that can block the electrical signal. In fact, it's estimated that about 20% of patients that have a heart attack go on to develop a heart block. Finally, it's worth pointing out that the electrical conduction system is kind of like the electrical wiring in the walls of a house. So it makes sense that diseases of the heart muscle walls, cardiomyopathies, and inflammation of the heart muscle, or myocarditis, can both cause heart block. An atrioventricular, or AV block, is used to describe when the signal is delayed or blocked when it's trying to move from the atria to the ventricles. First-degree AV block is when the signal is delayed, but still makes it to the ventricles. This type has a PR interval greater than 200 milliseconds. Even though these signals are delayed, in first-degree block they still reach the ventricles. First-degree block isn't usually associated with any symptoms, and treatment or management of first-degree block might involve identifying electrolyte imbalances or causes due to medications, although it usually doesn't require further treatment. Second-degree AV block can be split into two types. Type 1, called Mobitz 1, or sometimes Winky-Block, happens when the PR interval gets progressively longer with each beat until a P wave is blocked completely. So maybe the first PR interval is 200 milliseconds, then the next is 260 milliseconds, then 300 milliseconds, and then finally the next one doesn't make it to the ventricles, and you get what's called a dropped beat. When a signal doesn't make it to the ventricles from the atria, and if a long enough time passes by, let's say about 2 seconds, then the ventricle's pacemaker cells kick in, sort of as a fail-safe mechanism called a ventricular escape beat. Most people with this type don't have any symptoms, but occasionally people feel lightheadedness, dizziness, and syncope. Second-degree AV block, type 2, or Mobitz 2, is similar to type 1 in that you get intermittent drop beats, except that this time they happen fairly randomly, so you don't have this progressive lengthening of the PR interval. A lot of times a ratio for the overall number of beats conducted to not conducted is given, like 2-to-1 Mobitz 2 AV block. But again, remember that those drop beats happen fairly randomly, so we can't really predict exactly when the next beat will get dropped. Most people with Mobitz type 2 do feel symptoms, like fatigue, dyspnea, chest pain, and syncope, though the severity can vary from patient to patient. Third degree, or complete heart block, describes when the signal is completely blocked when moving from the atria to the ventricles, every time. So in this case, even though the atria might be going along at 60 beats per minute, as if everything was normal, none of those signals make it down to the ventricles, and the ventricles struggle along with escape beats at very slow rates, probably closer to 30 beats per minute. Patients with complete heart block are usually symptomatic, with symptoms ranging from syncope, confusion, dyspnea, severe chest pain, and these patients are at risk of dying. When someone has AV block, it's important to figure out the underlying cause and address it. For example, it could be an adverse effect from a medication or from an infection. In terms of treating AV block, typically a medication can be used to increase the heart rate, like atropine. Alternatively, transcutaneous pacing might be used where electrical pacing of the heart is done through electrodes placed on the skin. If the underlying cause is irreversible and the AV block is severe, patients ultimately might need a permanent pacemaker, which is implanted and continually monitors the patient's rhythm. And if it detects a delay, it'll send an electrical impulse into the ventricles, causing them to contract. Alright, as a quick recap. Atrioventricular block is a type of arrhythmia where the signal is delayed or blocked when moving from the atria to the ventricles. It's caused by Lev's disease, ischemic heart disease, cardiomyopathy, or myocarditis, and can be one of 3 types depending on its severity. At its most severe, the signal is completely blocked, with symptoms like syncope, dyspnea, and severe chest pain.
Is going to be bundle branch block.
Each heartbeat starts with the heart's pacemaker cells in the sinoatrial node, or sometimes SA node, in the right atrium. The SA node sends out an electrical signal that propagates out and contracts both upper chambers, then moves through the atrioventricular, or AV node, down into the lower chambers, where it reaches the bundle of His and then splits into the left and right bundle branches, serving the left and the right ventricles, respectively. The signal then goes on to each ventricle's Purkinje fibers, which leads to ventricular contraction. Now, a bundle branch block describes when the electrical signal gets completely blocked or held up along one of the bundle branches. In most cases, this block or delay is caused by fibrosis or scarring that either occurs acutely or chronically. Acute causes can be things like ischemia and heart attack, or myocarditis, inflammation of the heart tissue. Chronic conditions that might lead to fibrosis of the heart tissue include hypertension, coronary artery disease, and cardiomyopathies, because they can all cause slow and steady remodeling of the heart muscle. So if the block happens on the right side, it's referred to as a right bundle branch block. So with this type, the electrical signal starts in the SA node, contracts the atria, moves through the AV node, splits at the bundle of His, and then moves down the left bundle branch, but's blocked on the right bundle branch. And so the left ventricle contracts first. The signal then spreads from the Purkinje fibers to the left ventricle over to the right ventricle, which contracts, but this happens after the left contracts. So with the right bundle branch block, the right ventricle contracts late. If the block happened to be on the left side instead, a left bundle branch block, the signal would be delayed on that side, and so the right ventricle would contract first, and then the left ventricle would contract late. Now, on an electrocardiogram, or ECG, normally you have the characteristic P wave, which corresponds to the atria contracting, then the QRS complex, which corresponds to both ventricles contracting, and is usually between 80 and 100 milliseconds long. If there's a delay in depolarization of one of the ventricles, the QRS complex gets wider because depolarization starts on time but ends later than usual. Since now one of the ventricles is contracting late, a QRS complex longer than 120 milliseconds is common to see in a bundle branch block. Okay, so far we've been looking at a relatively common view of the heart, called lead 2, which is a type of limb lead, since we get it by attaching leads to the right arm and left leg, both of which are limbs. Even though this lead can give us some solid information, it's often helpful to use other leads as well, especially when differentiating between left and right bundle branch block. The chest or precordial leads are really useful for doing just that. Chest leads look at the heart's electrical activity when viewed from a slice parallel with the ground, so it's a bit different from the limb leads, which look at the heart in the frontal plane, which is perpendicular to the ground. For chest leads, they go from V1 coming straight out the front of the chest to V6 going out the left side of the chest. Each of these is like looking at the heart from a different perspective, right? V1 and V6 are particularly helpful because they're the farthest apart from each other, and therefore have the most contrast between views. Normally, the first thing to depolarize is the septum, and the wave of depolarization moves from the left bundle branch toward the right ventricle, so toward V1 but away from V6, meaning you'll get a positive deflection on V1 and a negative deflection on V6. Then that wave moves to the ventricles themselves, and since the left ventricle is usually more massive, you'll get a large depolarization directed away from V1 but toward V6, so negative on V1 and positive on V6. Now let's say that there's a block along the left bundle branch. So now the overall direction of depolarization comes from the right side and moves toward the left, so away from V1 and toward V6, meaning negative in V1 and positive in V6. V6 will also often be notched, from the left ventricle depolarizing late. So when it's all said and done, V1 usually has a QS or a little rs complex, QS meaning an absent R wave and little rs meaning a small R wave, either of which give it a W shape. On V6, the large notched R wave gives it an M shape. Alright, now let's say that there's a block in the right bundle branch. The first part is actually similar to the normal situation, right? So the septum depolarizes from the left bundle branch toward the right ventricle, so toward and positive in V1 and away and negative in V6. Next, the left ventricle depolarizes, and you get a negative deflection in V1 and a positive deflection in V6. Finally, as the right ventricle depolarizes in a roundabout sort of way, you get a positive deflection in V1 and a negative in V6. So V1 has a large terminal R wave, meaning it ends with a large R wave, and this gives it an M shape. On V6, there should be a slurred S wave, giving it a W shape. Now, if we look at all of these, you've got a W shape in V1, an M shape in V6 for left bundle branch block, but then an M shape in V1 and a W shape in V6 in right bundle branch block, which sets us up for this awesome mnemonic, William Morrow. Nailed it. Some cases of bundle branch block are present since birth, and don't cause symptoms and therefore probably don't need any treatment. In a lot of cases, though, the block is acquired through some other heart disease. In severe cases where the block is accompanied by heart failure, a special cardiac resynchronization pacemaker can be implanted that has electrical leads going to both the left and the right ventricles, and can pace them at the same time, causing them both to contract at the same time, which helps improve cardiac function. Alright, as a quick recap. A bundle branch block is when the electrical signal from the AV node gets blocked or delayed along one of the bundle branches in the ventricles. It's usually caused by fibrosis of heart tissue from acute or chronic heart disease. It shows up as a wider QRS complex on an ECG, and using chest leads on the ECG can help confirm the bundle block's location. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at Osmosis.
For the AV reentrant tachycardias.
The atria are the heart's upper chambers, and the ventricles are the lower chambers. Reentrant tachycardias are fast heart rates caused by electrical signals that loop back on themselves. Normally, an electrical signal starts at the sinoatrial or SA node in the right atrium. It then propagates out through both atria, including Bachmann's bundle in the left atrium, and then contracts both atria. It's then delayed just a little bit as it goes through the atrioventricular or AV node, before it passes through the bundle of His and onto the Purkinje fibers of the left and the right ventricles, causing them to contract as well. Usually, the only place where a signal can go from the atria to the ventricles is at the AV node. And once that signal gets to the Purkinje fibers, it stops, and the heart tissue waits for another signal from the SA node. With an atrioventricular reentrant tachycardia, or AVRT, the electrical signal actually uses a separate accessory pathway to get back up from the ventricles to the atria, causing the atria to contract before the SA node sends out another signal. The signal then moves back down the AV node to the ventricles and the Purkinje fibers and contracts the ventricles, as well as goes back up that accessory pathway, and then this cycle repeats, which is why AVRT can result in rates as high as 200 to 300 beats per minute. This type of tachycardia is known as a supraventricular tachycardia, because the signal causing the fast heart rate originates above the ventricles. The most common type of AVRT is Wolff-Parkinson-White syndrome, where the accessory pathway is called the bundle of Kent. This type of reentry is known as an anatomical reentrant circuit, because the accessory pathway is a fixed anatomically defined pathway. Another type of reentrant circuit, though, is atrioventricular nodal reentrant tachycardia, or AVNRT. AVNRT, just like AVRT, is a type of supraventricular tachycardia, but with AVNRT, it's in or near the AV node, which just like before contracts the ventricle and the atria every time it goes around. Specifically, there are two separate electrical pathways that make up this loop, and one of these pathways has heart tissue that has slow electrical conduction, and is called the alpha pathway, and the other has fast conduction, and it's called the beta pathway. Not only that, though, the alpha pathway has a short refractory period, which is the time it takes to be able to conduct another signal. The beta pathway, on the other hand, has a long refractory period. Once you have all those things, you've got yourself a recipe for AVNRT. So now let's say a signal comes down from the SA node in the right atrium. The signal goes down the fast pathway and reaches the other end before the slow pathway, and then splits to travel down to the ventricles, as well as up the alpha pathway, where it meets the slow signal and they both cancel each other out. At this point, both go into their refractory period. Except the alpha pathway is shorter, right? So it comes out of refractory sooner and it's ready for another signal, while the beta pathway is still in refractory. So if another signal comes by, it'll start down the slow pathway, but since the fast is still in refractory, it'll be blocked. At some point while the signal's going down the alpha side, that beta side will come out of refractory, and then it'll be ready to go. So now as that signal exits the alpha pathway to the ventricles and enters the refractory period, it also travels up the beta pathway, and by the time it reaches the alpha pathway again, that pathway is out of refractory. So now you have this reentrant loop set up that just keeps going and going, and every time around it causes both an atrial and a ventricular contraction, which again, just like AVRT, leads to high ventricular rates. This particular setup, where it goes down the slow pathway, or anterograde, and up the fast pathway, or retrograde, is called slow-fast AVNRT, or typical AVNRT. It's also possible to have the opposite, though, called fast-slow AVNRT, or atypical AVNRT, which, as the name suggests, is a lot less common than slow-fast AVNRT. With this type, the pathway goes down the fast pathway, or anterograde, and up the slow pathway, or retrograde. The tachycardia with AVRT and AVNRT typically doesn't last very long, and both are rarely life-threatening. They can, though, both produce symptoms like palpitations, shortness of breath, and feelings of dizziness, as well as syncope or fainting, in rare cases. With an ECG, the P wave is a signal from atrial contraction, and the QRS is the signal from ventricular contraction. On an ECG with AVNRT, the P wave might not be visible, since the signal is getting to the atria and the ventricles at almost the same time. So the P wave starts essentially where the QRS starts, and when you add them together, the P wave can get buried under the QRS complex. With AVRT, the P waves might or might not be buried, depending on where the accessory pathway is located. The definitive treatment for either AVRT or AVNRT is radiocatheter ablation, essentially destruction of the accessory pathway with AVRT and destruction of the slow or alpha pathway with AVNRT. For AVNRT, sometimes people can use vagal maneuvers as well, which are ways to activate the vagus nerve, which tends to block the AV node temporarily, therefore potentially stopping the episode. Some methods include a corroded sinus massage as well as a Valsalva maneuver, which is forced exhalation against a closed airway. Also, they might use medications to slow AV node conduction. In rare cases where other treatments haven't been effective, though, they might need cardioversion. Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel or telling your friends about us on social media.
All right, then back to the text, which we saw in the videos is explained quite well with our first degree, second degree, Mobitz 1, Mobitz 2. Those are pretty straightforward. Then third degree, we've lost our complete any association between the atria and the ventricle, life-threatening bradycardia, typically. So we talked a little bit about the tachyarrhythmia. Increased automaticity is favored by ischemia. The sympathetic nervous system can stimulate it. And it also happens during myocardial infarction because of disease to the tissues. Re-entry, they did a great job of explaining, it's facilitated by those converging pathways, whether it's anterograde or retrograde. That is explained very well in your osmosis video, so I'm not going to go through that again with you. I do want to point out that it's also known as the circus rhythm. Wolff-Parkinson-White was mentioned in that video as well. It's not a very common disease that you're going to see a whole bunch in practice, but it does exist, and it's important to understand what to look out for with that. This is a test kind of question that helps you, or you will see this again probably in some kind of test or certification, and the cue to remember is that this is the delta wave disease. So if you see a delta wave on a EKG, that's significant of Wolff-Parkinson-White. This is a dangerous reentry possible situation, and it can make people very symptomatic and pass out. So next we're going to go into AFib. I'm going to watch the videos on that as well. Remember, AFib is something you're going to see a whole bunch in practice. It's a very common disease that causes a lot of morbidity and mortality, especially in our older adults. It's the most common rhythm disturbance that you're going to see. The key about that is you don't have discernible P waves, and you have an irregularly irregular QRS complex, and your pulse is erratic. You can get AFib as a consequence of aging, but also years of hypertension can cause atrial enlargement, and with that, you create abnormal foci in the atria. Heart failure is a huge risk for AFib, and uncontrolled AFib can cause heart failure, and then valvular AFib. People can have AFib and be rate controlled and rhythm controlled, and then drink too much caffeine, alcohol, lung disease issues can arise. So caffeine and alcohol can trigger someone's AFib. So one of the things we talk about sometimes with patients is that, sorry, you can't have the cup of red wine or the glass of beer or a highball martini or whatever in the evening time, because alcohol can be a trigger for people. People that are smokers are at a higher risk of lung or of atrial fibrillation as well. And then it can be initiated by an ectopic foci at the junction of the atria with the pulmonary veins, which is why lung disease can be a big problem. The pathological consequences, as we all know, I'm sure by now, in years of practice for you guys, is that you're at risk for stroke because you get the atrial blood stasis, and then clot formation can happen, and that can travel to the brain and cause a TIA or stroke. So people with AFib will have their score of their CHA2DS2 score calculated, and pretty much only very rarely do people not need an anticoagulant. The other problem with atrial fibrillation is it does cause the inadequate cardiac output, and you lose your atrial kick, which decreases your cardiac output. People with atrial fibrillation may be in it and they don't know it because they don't feel tachycardic. They don't feel like they have any palpitations, but one of the first things that they do realize is that they have an increased activity intolerance. When you are dealing with atrial fibrillation, remember that you have the different kinds or labels to it. So you can have paroxysmal atrial fibrillation, which means it comes and goes. You can have chronic atrial fibrillation where it's sustained, and that is now pretty much your new base rhythm. So there's different labels to some of the atrial fibrillations that you'll learn later in your practice or decision-making in practice courses. All right, so I'm going to pop over to the AFib video quick. Going back then to the ventricular tachycardias as one of the topics that they bring up in your book. They're pretty self-explanatory. I'm not going to do an osmosis video about them. They are on there. If you wanted to read them on osmosis, you're welcome to. The reason I didn't is because I do think that atrial fibrillation is definitely one that you're going to see more than the ventricular tachycardia, so I wanted to focus us on that. So we covered going back down through what the book wants us to know, and we are going to wrap up part 1 with the 2 videos here.